Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday edition. Our speaker tonight is Dr. Mark Dunbar, who will be talking about clinical decisions in retina. It's my pleasure to introduce our close friend and colleague, Dr. Mark Dunbar, who's been a member of the optometric staff at the University of Miami's Bascom Palmer Eye Institute for over 30 years. And currently serves as the Director of Optometric Services there. He's also co-chairman of the Conference Advisory Board for Vision Expo. Dr. Dunbar is a fellow of the American Academy of Optometry, and is a founding member of both the Optometric Glaucoma Society and the Optometric Retina Society. He also serves on the editorial boards for Review of Optometry, where he writes the monthly column Retina Quiz, which must be marked over 20 years now.
Exactly, yep.
Okay, with that, it's my great privilege and pleasure to introduce my close friend, Dr. Mark Dunbar. Mark, take it away.
Thank you, Joe, for the introduction. Thank you, Greg, Vanessa, for coordinating. It is great to be back. Thank you for giving up time on a beautiful, day, Sunday night in August. I'm sure there's a lot of things you could be doing right now. So thank you for wanting to choose to spend 2 hours with us and me. This is a lecture that, in a sense, is really born out of working with students and residents and time on planes where you have nothing but time to think about how are we going to deliver a message, how are we going to get people to think about the decisions that we make on our patients on a daily basis. And so that's really kind of how this started, and it's meant to be interesting, it's meant to be entertaining. If we were live, I would welcome any comments or feedback. As it is, I will welcome any comments and feedback from Joe and Greg, anything that comes up, and they will read the chats. And so if anybody has comments as we're going through the chats, I would welcome them. The one thing that in my 30 plus years that I've learned, and I think that probably many of us realize, there's more than one way to come up with an answer, or more than one right answer, if you will. A lot of times, you're looking at somebody who has a corneal ulcer or a retinal detachment, for example, and those are things, right, that there is not more than one way. There's more than one way, but it is pretty defined. Some of the things we'll talk about tonight, there's differing opinions. There's, again, more than one ways to maybe come up with an answer, and so part of this is meant to kind of challenge and create discussion and generate some awareness, if you will. And the poll questions are not right or wrong answers. It's just, what would you do type things. What do you think this is type things. And again, it's meant to generate some discussion and thoughts and ideas. This is the Bascom Palmer Eye Institute, where I've been working since the late 1980s. As Joe said, I'm the director of optometry. For a long time, I was residency director. And of course, we've had, before COVID, we had students and with us. We haven't since COVID. We're hoping to get them back very soon. By way of disclosure, again, my goal is not to sell anything, be commercial in any way, but really just, talk about things that I think are interesting in terms of a clinical decision basis in retina. And so the idea is, from the second a patient walks in the door, we're faced with making clinical decisions and ultimately solving problems. Often they do arise from a chief complaint. It's maybe a patient that says, I have diabetes, or my vision is blurry, or I've got sandy, gritty, feeling in my eyes. I mean, a lot of times, through the chief complaint, whether it's the reason why they're there or just a byproduct of, they're in front of the doctor and want to address some issues, the minute we're in front of the patient, we're thinking about what's going on. What am I going to do to help solve this problem? Or, for example, somebody who's got lattice degeneration, or a funny looking retinal lesion, or drusen in the retina, right? You think about the clinical decisions that you need to make when that patient is in front of you. And again, the ultimate goal is, how can I take the best care of this patient? How can I identify problems either that are ongoing now or potentially that may come up? And how do I manage this patient to the best of my abilities? And I think ultimately try to keep the patient in your chair, right? We don't want to have to refer unless we need to. And when we do refer, it's because ultimately it's a patient who needs to be treated. And so, as in a way, an example, right? Why is my vision blurry? And sometimes they're simple, right? It's a patient who goes from a -1 to a -1.25 or a -150, or they've got a 2 ad and you just need a 2.25 or 250, or those are the simple ones that we think about. We don't even think about because they're just kind of automatic, right? They're ingrained. But other examples, right? A cataract, are they 20/40? Is this a 20/40 cataract, or is there something else going on? We talked about just simple changes in refractive. The patient who comes in with sandy, gritty, I feel like I have a grain of sand. I think we probably hear that a couple times a day at least, and automatically, again, you think, all right, this patient's got dry eyes, and that's going to be something we're going to need to address before all is said and done. Or, when you're at the salt lamp, you start looking, is there staining? Is there, meibomian gland disease, et cetera? The patient with diabetes, do they have diabetic retinopathy? The suspicious optic nerve, could it be glaucomatous? Or, on the right, you look at it, could this be a swollen nerve? And so again, just examples of clinical decisions that, we're faced every single day of our lives. And again, from the minute we wake up to the minute we go to bed, we're making decisions on, which way do I turn? Do I need gas? I need to watch out for this. Do I want to buy that? And eye care is just one of the many things that we, as I said, we do. And so I think, one of the fundamental principles, right, is just, pay attention to the key fundamentals of the eye exam. Take a good case history, not only a good ocular history, but a medical history, and be very detailed and organized in your exam, and make sure you address the key elements. Skipping any step can result in missing key findings. And certainly with the use of technology, it can be a great adjunct, but it should not be a substitute. And we'll talk about that as we're going along. The interesting thing about having students and residents, and really more students, when they're really faced for the first time of seeing a difficult and challenging patient. It may be a patient who's got, multiple things going on. It may be a patient who's got, maybe a language barrier. It may be a patient who has, profound vision loss, and it can be overwhelming, right? Especially if you've not had a lot of experience. And what I always kind of tell them is you start from the beginning, you go through the history. Everything you do should be a step or procedure, and it doesn't change whether, there's a lot of things going on or it's a patient who's just a simple emmetrope, right? You go through those same steps on every single patient that you see. You gather the information, and whether it's simple or easy, whether it's very complex, by doing that exam, you gather the pieces, you put the information together, and of course, the hope is that you arrive at really a good diagnosis. You're able to address the problem and be able to really answer the questions. And so, for those of you, and it's probably everybody on this who's listening in, I think you can kind of relate to that, right? The more experience you have, the more difficult and challenging patients you see, you recognize that you've got to really pay attention to those key fundamental principles. And then at the end of the day, making sure the impression and plan fit really the clinical findings and the chief complaint of why the patient came in. And so let's start out with a case, right? This is a 55-year-old Caucasian male. He presents with the sudden onset of a floater in his right eye. And he says that it feels like I'm looking through an oil slick or water. And so that symptom, that chief complaint probably automatically arouse, you kind of think about what's going on, right? Arouses suspicions of, oh, could this patient have a posterior vitreous detachment? Could they have a retinal tear? Could there be a retinal detachment? And that's kind of when somebody comes into those symptoms, that's really what you think about. So yes, 20/20 in each eye, their confrontations are full to finger counting. You dilate the patients with tropicamide and neosynephrine. You look with your 90 and you put on your Endurec, you look with a 20 diopter lens. Maybe you've got an Optos or a wide field camera and you take a picture. You note the presence of a Weiss's ring, and you note that there is an attached retina. And so this doctor diagnoses a posterior vitreous detachment, probably like all of us. That suspicion was there. You go through the exam, you kind of put everything together, and you make the diagnosis. So he educates regarding the signs and symptoms of a retinal detachment and explains the need to return immediately if the patient should see any of these symptoms. And then he tells the patient to come back in 1 year. And so when we talk about clinical decisions in this exam, right? Did the OD manage this patient correctly? Symptomatic PVD, he dilates, he looks, finds a Weiss's ring, educates the patient, and then tells the patient to come back yearly. And so to some degree, you're thinking about this in maybe a critical way, right? And I'll tell you, this does become a malpractice case. And I know that Joe and I, and probably Greg and I, have discussed this case over the years and when I've given this talk before. But the question is, was there anything else that the patient or the OD should have done? When you think about this, right? He dilated, he looked with the 20, he documented the presence of a Weiss's ring. Is there anything else he should have done? And so really the question is, was he obligated to do scleral depression? And really the fundamental question is going to be, do you think that is within the scope of licensure for an optometrist, right? Was he obligated to do it? And if he didn't do it, did he fall below the standard? Based on the symptoms of, I'm looking through an oil slick, should he have, maybe referred this patient to a retinal specialist? I can tell you, when one expert witness who was an optometrist read the case, they said, just based on those symptoms alone, this OD shouldn't have been following that patient. He should have immediately sent the patient to a retinal specialist, because that looking through water is really pathognomonic or indicative of the patient perhaps having a retinal detachment. And so, Joe, or Greg, I'm going to pop this up. I don't know if this will show up on your end, or if this is set up on your end. Do I need to go to the next slide, or do you have this set up, Greg?
That's a poll everywhere. So I took it and put it into Zoom, and it's already launched. It says a 55-year-old with symptoms of flashes and flares.
Okay, that was okay. I just wanted to make sure that we were on the same on the same page. So yes, the retina's flat. You don't see a tear. Would you do scleral depression? Were you going to say something, Joe?
No.
Okay. I'll tell you, I've had, and again, I know Joe does a lot of malpractice as well. And I know between the two of us, we've had bunches of these, symptomatic PVDs where, patient ultimately develops a retinal detachment. And so did the OD miss a retinal tear? Did they, miss the presence of a retinal detachment? And again, it kind of falls back to that, making sure you do a detailed, thorough exam, making sure you don't skip any elements, dilating with 2.5% neo and Madriacil, noting the presence or absence, the pertinent positives and negatives. Was there any pigment in the vitreous, i.e., Schaefer sign? Did you see the presence of a posterior vitreous detachment? And again, if you really want to be thorough, do scleral depression. A good friend of mine, Steve Frucci, and Steve and I have lectured together, and Steve always jokes that, and we'll look at what the AOA says about this. And it's, maybe a little bit ambiguous, because anytime there becomes a malpractice case, obviously the attorneys are going to go to what are the preferred practice patterns for your profession. And there are some guidelines that have been put forth by the AOA, and it is suggestive that you probably should in patients who have symptomatic PVD. And again, it doesn't say you need to be good at it, right? And that's kind of the joke, is I would do it, I would attempt it. And then the joke is I'd make sure the patient, it's a little uncomfortable, so the patient kind of remembers that you did it, just in case, something goes awry. But I would do it. And I do it on all my patients who have symptomatic PVDs that come in. And again, I think it just gives you an opportunity that, especially these subtle, if they're kind of, shallow, tears, it gives you, I think, maybe a better opportunity to see them.
And Mark, it goes without saying, but I do want to say it is, whatever you do, make sure you write it down. What lenses that you use, what drugs that you use, is all very important. As you said, as Mark mentioned, attorneys, there are some that are sharper than others, and some will go to the AOA and look at the practice guidelines, and some will actually go to state boards and look at the practice guidelines of your state board and bring it up, and some will not. Some are not that sophisticated.
Yeah. And now that we're in an electronic health record, it's been much better than it was, 10 years ago, when we were looking at paper charts and, trying to read handwriting, trying to see what was done, a little circle with is this a retina, and incomplete or poor notes. And I think the one thing with an electronic medical record is afforded is the fact that, you are able to, things get checked off, whether you did it or didn't do it, at least it's there. And the idea is that you probably did it. And again, you're not having to read, poor handwriting and things like that. So I think that's been a great help from, me being an expert, having to look and review medical records to see that everything is done. And in the 2 or 3 cases we're going to talk about, I'll talk about another one in a minute. Again, it's nice to see an electronic health record that has the pertinent information there. Do we have the results, Greg?
There you go.
I didn't see him.
They're sharing. So basically it says 34% said yes and 66% say no.
And that tends to be, when we've done this live and done the poll everywhere, that's been about it. That rank and file, most people would not do it. And again, about a third of the people, would do it. About 2/3 of the people would not do it. And again, I would have you, think about that, and you can be stubborn about it. And are we held to the same standard of a retinal specialist? Well, probably not. But yeah, let's look at what the AOA guidelines say, right? So this was from 2004. They talk about, ocular examination. You kind of look at the bullets or binocular indirect ophthalmoscopy, and then I have squared out with scleral depression if indicated. They go on to say that scleral depression may be needed to detect small asymptomatic peripheral retinal detachments. So, it's a little vague. What does if indicated mean? And I think we kind of recognize if somebody does have something suspicious, or if they've got maybe symptoms, you could argue that, maybe it is within the scope of practice. And again, I do it. I would tell you, you should try to do it again, just because if something comes up, you scratch it off the list of really it being an argument, it being a kind of an area where an attorney can make that a focal point of the lawsuit, if you will. And so, of course, the rest of the story, the patient returns about 5 weeks later complaining he can't see out of his right eye for the past 4 days. He has a macula-off retinal detachment. The RD gets repaired, but at the end of the day, he ends up 2,200. I'll tell you the other kind of aspect that I don't know if you were thinking about it. We didn't bring it up, but you look on the bottom here, return in 1 year. That was the other issue that came up in this patient. The fact that they're symptomatic PVD, you should make sure you bring these patients back maybe 2 to 4 weeks, no longer than 6 weeks, but 2 to 4 weeks is ideal. And then the idea, do you need to do scleral depression? So these were kind of two bones of contention that, we had to defend on this, for this OD. And ultimately it ends up, getting kind of settled, never went to trial. And I thought it was something we could defend, but again, somebody who's got symptomatic PVD, make sure you bring those patients back. And so here's another one. This is a 61-year-old white male, onset of flashes followed by a floater in the right eye for the past 3 to 4 years. And so, again, almost everything perfect, right? Sees the OD, 20/25 acuity. But in this case, the OD only dilates with 2.5% neo. And so that becomes a red flag, right? Examines with binocular indirect ophthalmoscopy, takes optos photos. He diagnoses vitreous syneresis. He notes the absence of tobacco dust or Schaefer signs. He explains the signs and symptoms of a retinal detachment and has the patient come back in a month. And so really does almost everything correctly. The question is 2.5% neosynephrine a strong enough dilating drop when somebody who's got a symptomatic PVD? I would also question, I think we know what vitreous syneresis is, but, as a diagnosis, would you put that? And again, I would say in a medical record, if you didn't see a Weiss's ring or a PVD, I would say no Weiss's ring or no PVD seen. And I would probably even as a diagnosis, I would probably use, flashes, photopsia. And so patient comes back 3 weeks later, 20/25, the blob is not as dark, sees many little specks. But now he's saying as it's dispersed, he's having more trouble, at a computer reading. Again, the OD dilates with 2.5% neo, evaluates the superfield 90 BIO, takes an optos photos. Unfortunately, the optos photos were not really well exposed. The quality of the pictures were pretty poor. So again, diagnosed with vitreous floaters, has the patient come back in a month. So the patient calls the office 2 weeks later saying vision is getting worse. Of course, the OD says right away, we'll just go directly to the retinal specialist. And as luck would have it, he's diagnosed with a macula-off retinal detachment, has surgery, including, membrane peel. So he has multiple surgeries, scleral buckle. He develops an epiretinal membrane. He has a membrane peel, develops a cataract, ends up having cataract surgery. But again, when all is said and done, the patient ends up at, 20/80 to 2100. And of course, he thinks that somebody's at fault and did the OD miss a retinal tear on one of those visits. And so, yes, he gets an attorney. The the record gets sent around. And so, yes, from my perspective, is this something you can defend? And again, I think the OD did everything well. And the only kind of question would be, is 2.5% neosynephrine an appropriate drop to dilate a patient with? And I think we would probably all recognize, somebody maybe blue eyes, I think you can probably get a decent enough dilation, but somebody maybe darker skinned or darker pigmented, brown irises, maybe not. And I would say the way to completely avoid it is to not just dilate with 2.5% neosynephrine. I ended up seeing, I was lecturing at a state meeting, and the OD who happened to be in the audience and came up to me afterwards, and this was my patient, and he talked about just the emotional toll of going through a situation like that, as you can imagine. But he did really talk about the fact that it really changed how he takes care of patients. They do things very differently now as a result, and part of it being that when they dilate a patient, they're not dilating with just 2.5% neosynephrine. Joe, I was sent a case probably a month ago, another one. And the gist of it was, the patient sees an OD, they've got symptoms in the right eye, the OD dilates, does everything. Again, the problem was he only dilates with 2.5% neosynephrine. And lo and behold, I think 10 weeks goes by and the patient develops a tear in the left eye. So symptoms in the right eye, ultimately 2 months later, 2.5 months later, develops a detachment in the fellow eye. And so, yes, it becomes a malpractice case. And again, it was another example of, gosh, why didn't the OD dilate with Medriosil and neosynephrine? And that's, everything done exactly right, other than this bone of contention is 2.5% neosynephrine, enough of a dilating drop to be able to look at somebody who's got, the potential of peripheral retinal pathology. And again, as a defending an OD, I don't want to be in that situation where you've got to kind of wonder. So I think one of the morals is these cases do come up. They come up more often than they should. Make sure if you're going to follow a patient, and again, from an OD perspective, I think we're all capable of doing it. If you feel that your clinical skills and ability are not sufficient, or you don't want to put yourself at risk, I think it's perfectly fine. Joe, you probably remember we had an ORS meeting in Central Florida, and we had a group that was a group of retinal specialists. And to me, they were talking about this very thing. And it was really kind of as a matter of fact type of thing that really kind of hit home. They go, listen, if you don't feel comfortable managing it, if you don't want to take the risk or incur the liability, send it to a retinal specialist. And when you do that, it takes that burden of responsibility off of your shoulders and puts it onto that of a retinal specialist. And it's kind of simply put, but there was, I think, some wisdom to that. And so again, depending on your clinical skills and ability, your time, remember bringing the patient back is critical. But if you're going to dilate that patient, make sure you dilate with Medriosil and neosynephrine, or cyclogel and neos, whatever you want. There, you can use a cocktail, but don't use simply neosynephrine as a dilating agent. I think there's a potential of getting into some trouble. So
hey, Mark, there's a question that rolled in,
yep.
and then I'm just going to make a comment, because doing these for a little over a year now, we always get yelled at in a nice way, meaning in the survey for
Yep.
saying abbreviations. So ORS would be the Optometric Retina Society. Is that correct when you said that?
It is. Thank you. Thank you.
Had a meeting. Yep, no worries. So there's a question here. It says, I'm not sure which case it is. I think it might be the first one. It says, any issue that the patient didn't come in sooner if he couldn't see for 4 days?
Correct. So you're right. So even though the OD says come back in a year, here's a patient who has symptoms for 4 days, and sometimes it's longer than that. There should be a burden of responsibility on the patient, right? If they're noticing a change or it worsening, correct, right? Some responsibility should be on the patient's shoulders. And I think we see these type of situations over and over and over, not just relating to, peripheral retinal pathology that leads to a retinal detachment, but listen, you don't need much to decide you're going to sue, and whether they were right or not right, they initiate the lawsuit. You've got to, take your stand. You've got to get your defense. You've got to kind of look at everything. And so I don't disagree at all. We see more egregious from a patient perspective problems than that. And yet, it's still as the OD, the burden of responsibility is to prove your innocence, that you didn't fall below the standard of care. And it's unfortunate, but often sometimes that happens.
The
Any
next
comment?
one is, and
Yep.
yeah, the next one that came in, there's 3 or 4 here, and if Joe wants to take care of the next
Yeah.
one, but I'll do this one. It says, I know some retinal specialists dilate only with 2 drops of tropicamide. Any opinion?
Well, I do think tropicamide is it personally. I think it's a good enough dilating agent. Certainly, if you're going to use one medication, tropicamide is better than just as neosynephrine. So I mean, I think you do get a really good dilation, decent dilation with tropicamide. Again, my personal experience is we do both. It's just kind of the nature of it. In every practice I've been at, even when I was at the Omni in Lexington, the cocktail was Madrayacil and neosynephrine. So, but again, it only becomes an issue if somebody decides to, challenge through the court of law, and then you've got to explain it. But I think most people would agree tropicamide is probably acceptable.
And there's one that, go ahead, Joe.
I was going to say that if I were defending a case for tropicamide reuse, I'd agree with you, Mark.
Yeah.
I would say that. Now, if I were hired to opine against the doctor and it said 1% tropicamide, I'd say, yeah, it's not ideal, but it's good. It was fine. So either way, I mean, I would agree with myself and with you. It's fine.
Yeah.
There's a private one that came to me, and it says, any issue if the patient refuses to go to the ophthalmologist?
It's
I would just say document it, right?
Yeah, exactly. That's exactly right. Document it.
That just, encourage patient to see ophthalmologist, retinal specialist, blah, blah, blah. Patient declined.
Yeah.
Document it. Unfortunately, people will not want to hear this, but unfortunately, patients cannot be held responsible for their own negligence.
Yeah.
That is a legal precedent.
Yeah.
So we have someone just trying to get clarification here. It says, so if it just bumped on me, it went up because someone asked something else. Let me find it here again. If you have a symptomatic patient, you're basically saying to use 2.5% and 1%.
Yeah, that's what again, I think that's ideally, that's what we typically use. Again, better safe than not getting a good enough dilation. You just heard
someone here is just
only use tropicamide, and I think that's fine, but go ahead.
Yeah, I think I would agree that, if the patient's eye can handle it, without any, I guess, if you want to go way out in left field, hypertensive crisis, whatever, if you have 2.5% and tropicamide in your office on a symptomatic PVD, that's the way we'd probably all recommend here, taking into account then someone here put in shallow angles and maybe systemic health and so on and so forth. And that would be the reason. But if you have, patient come in, they're symptomatic, I think what we're all advocating for here is 2.5%.
I worked with a retinal specialist, an old school guy, that every patient not only was, tropicamide, 1% tropicamide, but it was 10% neosynephrine. And he practiced for 40 plus 50 years and never had a problem with cardiovascular issues. So I know we were taught it, but I can just tell you in the real world, they never even blinked an eye. 10% neo and 1% tropicamide.
Oh yeah, I would say that would be the rule and not the exception with Retina.
Yeah.
Mark, a number of people have come up with questions about narrow angles and risk of angle closure. I've got my thoughts. What are your thoughts?
Well, I think, in the setting of a symptomatic PVD with narrowed angles, I would definitely refer that patient for an LPI. If you think it's an occludable angle and not safe to dilate, and they've got, the potential of peripheral retinal pathology, I think that's a patient that, probably, you talk to your local comprehensive ophthalmologist to get an LPI done, today or tomorrow, because they've got peripheral retinal pathology. And so I wouldn't dilate. I think there's medical legal issues from that alone, right? But I do think they probably need an LPI, and that patient ultimately then needs to see the retinal specialist within a day or two. That's how I think.
Or send to the retinal specialist, and she or he can make the determination.
There you go. That's a good one too. Yeah, that's probably makes more sense.
And I'm getting actually less with the research that's come out recently. I'm less concerned about the prophylactic LPI and dilating the narrow angle. And yes, indeed, you have to bite the bullet and maybe deal with the consequences. But I think we're seeing now that we may have been doing too many LPIs.
Oh, no question.
And I agree, Mark, with the 10%. I mean, I worked in ophthalmology for many years, especially in the cataract realm, and they want 1% and 10% because they want to have no surprises when they get in as they're evaluating that cataract. They don't want to have any surprises getting into the operating room where they have to use iris hooks and so on and so forth. So, I think if anyone has any fears out there about phenylephrine and all that hypertensive stuff that we've been taught, we've seen 10% used for many years. So.
Yep.
All right. That seems like it's pretty much rolled. Everything's kind of becoming.
I'm glad we had questions. When we do this live, it always does generate questions, and I'm glad we were able to address it because, it's sobering, right? This is almost every day, if not several times a week, you'll be faced with a patient who's got symptomatic PVD, and often it's straightforward. Sometimes it's not. Obviously, do I bring them back? Yes, you should. Do you need to document? If when in doubt, refer the patient. But yeah, this is something that, is not uncommon. And again, you want to avoid falling below the standard of care or having a patient develop a problem and you being looked at, did this OD not do what they should have done?
Hey, Mark and Joe, I have just a personal question because I do scleral depression in the office. I'll admit that I'm not always getting the best views. So what I've resorted to is a Goldman 3 mirror with the different lenses angled. They say use the thumbnail, but whatever the next one over is, you can get out there pretty far, especially when they're dilated well. And I find a lot of tears that way is by using a nice, Goldman. Does that in a sense replace scleral, or do you think scleral depression is the way to go because of the way you're kind of maybe manipulating and maybe getting that tear to open up?
I think again, from a standard of care perspective, I think you would not be faulted. Obviously, did you fall below the standard? No, I think you went above and beyond it. 20 years ago, 25 years ago, that really was putting on a contact lens, a 3-mirror lens and looking. We used to do it. I haven't done it in years and years. There's no question you need that dynamic because a flap tear that, sometimes you can only see it by, with scleral depression. So even with a 4-mirror lens, you might, or 3-mirror, you might miss that flap. But again, somebody who does that, I think you'd feel pretty confident that this is an OD that went above and beyond. And again, considering they did everything else well.
And my last comment will be, and I don't expect everyone to have that, but when I worked in the ODMD place and I got all excited one time and found that, I found a horseshoe tear and the ophthalmologist came out and said, yeah, you did a great job, but there was 2 other ones I found, but the cool thing was what they taught me. They're like, well, look, I'm going to have you look with this lens, like the, I don't know, it wasn't the PRP lens. Maybe it was, or it was whatever lens it was. But it was like the whole retina. It was like looking at the whole retina, like with a 20, and that's what it was, their laser lens. So I actually have one of those laser lenses that I use, and you literally put it on their eye and you can pretty much see, and maybe you have to rotate a little bit, but you can almost get a whole 360. It's a contact lens, you have to numb the eye and use a little contact, a little Celluvisc. But that's pretty amazing. That's another clinical pearl that I'd point out. I kind of said I did a Goldman 3 mirror, but that's probably the lens I use the most is that laser lens. So.
We had one of our residents went into surgery, our optometry residents. And it's funny you say that because this was about a month ago. And he said, that's exactly what he said when he put this laser contact lens on. He goes, it was like seeing the retina, just as exactly as you described it, Greg. It was like the whole retina and, just, you could see everything. And it's like, to your point, why don't we use that in clinical practice? And I've never used it, so I can't relate to that, but he was just really overwhelmed with the great view that they were able to see. And why don't we, this was in the setting of an operating room. So, but yeah.
In the next meeting, I would encourage people that would think that they're at the academy, like when Volk is there, they have those laser lenses there. I would encourage people to check that out. It's a contact lens, but man, you get a great view of the retina. You're not going to miss much. So,
yeah.
All right, go ahead.
Yeah, so PVDs, you can read it. 2/3 of people over the age of 65, more common in women, more common following surgery, more common following inflammation. Again, it's something that we see on a daily basis. I can tell you, it's interesting. My personal story, I was speaking at the Monterey meeting in probably 2 or 3 years ago, and I'm sitting in the hotel and working on a talk, and all of a sudden, I get this shower of floaters and black spots, and it's like, holy cow. It was in my left eye, and it's like, I was like, oh my God, I'm getting a retinal detachment. It just more than you could count. It was really, like kind of scared me. And so, it's a pretty big meeting. So I think I gave the lecture and went down to the exhibit hall. And so they had a wide field camera. I don't know if it was an Optos or a Claris, but I had a picture taken. I had an OCT taken, and no, I didn't have a retinal tear and a retinal detachment. Thank goodness. When I got back to Miami and, at Bascom Palmer, I saw a retinal specialist and had them look and didn't have one, but it was like, holy cow, it was a sobering reality. So I could kind of relate to what patients are saying. And again, I had the smartness and awareness of, knowing, being an optometrist, what was going on. And luckily I didn't have anything that was really worrisome. But again, anytime you think of or see patients with those symptoms, again, the idea, symptoms become critical, symptomatic, right? So retinal tears occur in about 8 to 15% of eyes with symptomatic PVDs, 90% being superior. Vitreous hemorrhage occurs in up to 13 to 19% or almost 20% of symptomatic PVDs. So again, vitreous hemorrhage or blood in the vitreous and a PVD, 70% will have a retinal break. PVD with no vitreous hemorrhage, only that number goes down to about 2 to 4%. So that's why it does become pretty important to scrutinize the vitreous. Do you see any blood? I remember years ago seeing a patient who was a high myope. And again, symptomatic PVD, I dilate the eye. There's layering of blood along the arcade inferior, right? And I didn't see a retinal tear. I mean, I looked scleral depressed. I mean, I just scrutinized it and did not see a retinal tear. And so, in this setting of a high myope with blood, here's the clinical decision, right? Do I refer this patient to a retinal specialist, even though, I felt pretty confident there was no retinal tear there. And I ended up doing it, right? Just because, with those odds, I remember a retinal specialist once telling me, if you see blood in the vitreous or pigment in the vitreous and you don't see a tear, go back and look again because you probably missed it. So, here's somebody, a high myope, layering of blood, it's got to be there. And so again, from not only a medical legal perspective, but the fact, I've got retinal specialists that are, a floor away, I go, let me just not incur that liability. Let's get the patient to see a retinal specialist. And if this was my mom or dad, that's probably what I would want. And as it turned out, the patient, they didn't see a retinal tear either, but it was, again, faced with that clinical decision, do I refer the patient? And I just thought, with those odds, knowing the numbers, it's probably in everybody's best interest for this patient to see the retinal specialist. And again, this is a couple slides that I think pirated from Leo Sims a few years ago. You're looking on the left, looking at obviously the disc, you pull back and you see on the right that Weiss's ring. I think, all of us have pretty routinely see that, right? So examining a patient with a symptomatic PVD, have a high suspicion of detecting a Weiss's ring and a high suspicion that there's a possible retinal break. Your exam should be conducted with these suspicions. All the testing procedures that you would normally do, dilated fundus exam, look at the anterior vitreous, note the presence and absence of pigment cells in the anterior vitreous. Peripheral extended ophthalmoscopy. And I would tell you, including scleral depression, again, doesn't mean you have to be good at it, just that you do it and you document that you did it. And so symptomatic flashes, PVD not seen, what is your management? I think, again, whether that 2 to 4 weeks, but I think it's important you bring that patient back. And even if maybe there was a tear that you didn't see, it gives you a second opportunity to look again, just to make sure that, maybe it is there, or perhaps it developed. And again, from a, business perspective, it's a way to keep that patient in your chair. You can bill another, probably comprehensive eye exam level 3, or, follow up if you're using eye codes, whatever it is. And so symptomatic flashes, but a PVD is seen, what is your management? Do you bring the patient back? And again, generally speaking, you should bring them back, right? Bring them back, maybe not as critical as it was, not 2 to 4 weeks, but I think you have a little bit of latitude. And so again, if we were having a discussion live, I'm sure, the patient who comes in that, they were symptomatic 3 months ago, right? And 3 months goes by, now they're sitting in your chair and you see a Weiss's ring. Do you need to bring that patient back? And, and I would say probably not. Again, you've done everything, you've looked, this is a pretty straightforward PVD. I probably wouldn't, but again, it's one of those things that every circumstance is different. And what is your comfort level? Obviously, explain signs and symptoms and bring them back one more time if you need to, but That's kind of how I would approach that. And again, just a couple examples, right? This is a retinal tear. You see a bridging vessel, and again, patient has traction, that vessel avulses, and of course you can see why they might develop a vitreous hemorrhage. Not sure it's the same patient, but again, you're looking at somebody who's had, just laser, wall it off, the patient ends up doing well. Another peripheral retinal tear, not a macula-off, but you see this peripheral retinal detachment. Just, schematic of a giant retinal tear. And I think sometimes a picture, helps kind of put things together. And that's kind of an example of that. This was one of those ODs on Facebooks that, I love, looking at the cases that get posted. I know Joe and Greg are very active on ODs on Facebook. And I love it when people submit cases. And again, just because what we do every single day of our lives, right? You see that interesting patient, you want to be able to share it, or, you're not sure maybe what to do, and you put it out there, and yeah, there's sometimes a lot of noise and people are a little bit flippant, but I think it's really very helpful sometimes if you're not sure what it is, or have you seen this before? And then again, this is just an example, right? This is the typical, this is my Saturday morning at 8 o'clock, patient comes in, or the Friday afternoon at 5 o'clock. And I just think when you think of optometry sees what, I think 88 to 90% of all eye exams across the country, it is a significant number, and we are the first line. And this is an example of, an OD who, peripheral retinal detachment, and just documented beautifully with their camera. I think it's nice. Here's one that I saw, probably within the last year, right? This ends up in our electronic health record. A patient sends me a message, right? And they sent it on Sunday. I don't think I get it till Monday, right? So, hi, Dr. Dunbar. This is such and such. I saw you once and got a prescription for glasses. I made a follow-up appointment, but due to COVID, it was canceled. I used your prescription to obtain new glasses. I think the prescription was 8 months old. It was really like 2 years old, or 3 years old, by the way. But so the purpose of my message is to ask you about floaters in my vision. For the past 4 days, I've had a tiny black dots in my vision, more without glasses and less with glasses. Is this normal? Will it go away? Do I need to make a Zoom appointment? Thank you for your response. So again, I get this on Monday and I go, oh, a new onset of floaters needs to be looked at. It may be normal physiologic change, but it could also be from a tear in the retina. I'm happy to see you this week, either at Lennar, which is one of our satellites. I'm there 2 days a week, or on the medical campus, which I'm also there 2 days a week. Let me know what you prefer, but we need to see you. I probably should have said I need to see you today, maybe tomorrow, but I said we need to see you this week. And so, she says, I can come in. I'm not sure if this was the same day or the next day. I can come in tomorrow at Lennar. Anytime is fine. And then I go, and this happened to be Tuesday. The next day I can see you tomorrow at Lennar, or on Thursday on the medical campus. I will have appointments reach out to you. So later Tuesday, should I call the scheduler? Bottom line is she comes in. Thanks for your quick response. I can come to either campus, whichever you prefer. So she comes in. Remember, her symptoms started, Sunday, 4 days earlier, right? So that was Wednesday, Thursday, Friday, Wednesday, Thursday, Tuesday. I finally get her in on Wednesday, and boom, look, right? She's got retinal detachment. Let me see if you can see am I able to show my laser pointer? Boom, let's do that.
Or we can certainly see your
okay, good. So you see a retinal tear up here. And you can see this boom, like just kissing, just straddling the fovea, right? So I don't know if that's macula on or macula-off, but it's suspicious. Here's our OCT, and you can see it's right there, right? And so here's the question, right? What is the time frame that she needs to be treated before it affects her visual outcome? Is it within 24 hours? Is it within 3 days? Is it within 7 days, or within 14 days? And so we're going to make this a poll everywhere. Now, the question is not when do you refer it, right? This is a patient that you probably need to get referred. I would say, have them come today, no later than tomorrow. If you have a good relationship with a retinal specialist, you call them up, listen, I've got either macula on or just macula-off. But the question is, when does this patient need to be operated on? And for it to really have an effect on visual outcome, does that need to be within 24 hours? Does it need to be within 3 days, within 7 days? And so again, you think about this, and this is a question that's been really asked among retinal specialists. So what if it's it's a Thursday, right? And if you're a retinal specialist and you don't operate on Friday, can it wait till Monday or Tuesday? What is the time frame? Do you need to, maybe it's a Friday and it's late, or even a weekend? Do you need to mobilize an operating team to come in and operate? So you think of the cost and economics of doing something like that. And again, if we think the answer is within 24 hours, then indeed maybe you do that. But the question is really, what is that time frame before it really becomes visually significant, before it can affect the visual outcome? If it's a Friday, can it wait till Monday? Are we going to do any harm by waiting before this patient actually has surgery? Do we have any poll responses yet?
We do. We reached 100% on that. Thanks, everyone.
Wow. So, but I can't see it.
Okay. I'm not sure why it's not sharing on your end, but I'll
able
read you the results. It says within 24 hours, 72%, within 3 days, 17%, within 7 days, 7%, within 14 days, 2%. And then I added also, I don't know. That's why I'm here. That was 1%.
So the answer is within 3 days. So 72%. I mean, obviously it was my eye or your eye. We would want it operated on within 24 hours. But the answer is really it's within 3 days. So
and the key there, Mark, is because it's macula-off.
Correct.
Right. That's the key of what within the 3 days. Yep.
So predictive factors, right? Initial presenting visual acuity. So somebody with better acuity. I think our patient was 20/30, 20/40, versus somebody who's got 2200. Duration of the macular detachment, obviously longer the macula-off, the worse the visual outcome. Height of the retinal detachment. So supposedly the more bullous the detachment is, the worse the outcome. So this was a study. I thought I had the reference. Maybe I do, but best visual outcomes when surgery performed typically has been within 7 days, but meta-analysis has shown a delay of more than 3 days was associated with a statistically worse final visual outcome. Eyes that had surgery within 3 days averaged a final visual acuity of around 20/30, and eyes that were operated on between that 4 to 7 days had a final visual acuity of 20/70. So again, traditionally thinking, if it's macula-off, how long has the macula been off? It was traditionally among retinal specialists, and probably still is, that you've got about 7 days. So again, the idea, maybe it's a Labor Day weekend, or maybe your surgeon, your retinal specialist is on vacation. How long can you wait? And it was believed that if within that 7 days you were okay, after 7 days, then again, the likelihood you're going to end up in that 2100 to 2200 range. But again, this is a study that showed that if it was more than 3 days, that became really the barrier for getting that better than 20/40 visual acuity. So I thought that was really pretty interesting. I don't know why I didn't have the reference. So here she is 8 weeks after. So again, the idea, symptoms for 4 days, I saw her within that week. We don't know how long the macula was off. But here she is 8 weeks after having pars plana vitrectomy, endo laser, and she ended up, this was 8 weeks at 20/40. She did start to have a cataract, and I think ultimately, which is very common, right, when you have vitrectomies. And I think she had some gas put in, maybe, I can't remember, but ultimately had cataract surgery, and I think it probably had a better final visual acuity outcome. This was the wife of our photographer, who came in, and she's a high myope, but again, just I think a beautiful picture with wide field imaging, kind of highlighting she's macula on, but again, you can see this, tear there. And this is imaged with the Claris, and this is with the Optos. And I think both of them do a good job. I like the Claris because it doesn't quite have the lashes, but no question, I think, both of these devices do a really, really good job of capturing a wide field image. And this is just blowing it up. Again, both of them, I think, give you really nice resolution. And so lattice degeneration as a routine finding, is that any cause for concern?
Let's do a little pause here for a second. Since we
Okay.
defined macula off 3 days, and you just showed a couple pictures of macula on, when's that patient going to have surgery?
That's a good, I think macula on, I think it's from a surgeon's perspective, they're kind of next available.
Right. It's, from my area where I work, and we have a retina group that's within, right down the road, but they have a bunch of offices, right? They come up from Pittsburgh, and I'm 70 miles from Pittsburgh. They'll say within 24 hours, they'll ask, when was the last time they ate? They'll say, make sure that they're NPO
Yeah.
after midnight. They'll evaluate them, and then they'll do surgery the next day.
Yeah. So we have, they have retinal specialists, and, at Bascom, they'll have usually a couple, 2 days or 1 day that they operate. So they won't bump somebody if it, 24 hours, just be, no question, you want it done as soon as you can. And I wouldn't disagree. Ideally, if you can get it within 24 hours, you take away any potential risk. So yes, but I think, if it's Macula-Off, you've got a day or two probably. Again, the idea that if it's a Friday, are they going to bring a team in on a Saturday and Sunday? And the answer is probably not.
Mark, what I've seen in our group is with what you just described on Friday. They've had a meal already. What often they'll do is they'll inject in the office, inject the gas bubble, do pneumatic retinopexy, and buy themselves time to then get in the operating room 3 days later.
Good point. Yep. I think, that's exactly right. Injecting gas, and that gas tamponades the retina. And yep. And if you can laser it and not need to do a buckle, and you don't lose anything, if it fails. So
yeah, that usually just buys them time to get the person on call, or get them in after the weekend, or some such thing.
Yeah. So I think the take home here for optometry would be, if the macula is off, you can advise the patient, look, we're going to get you there soon. Don't expect surgery, maybe up to 3 days. However, if the macula is on, I would encourage every optometrist out there to make sure they make the phone call. Yep. Let them start asking the questions. Did they eat? Did they do this? What's it look like? And they're going to see them that day. And then, or if it's really, really late, early morning the next day, and then they're going to do these things that Mark and Joe are talking about. But the key is macula on. You make the phone call and you let them start discussing. Mark, there's some comments in here. It goes way back. It says, what if you feel the patient has a poor cooperation? This was during the PVD evaluation and talk, would you refer? I think the answer is, if you don't feel you got a good exam, you either refer to another optometrist, or, maybe someone in your practice or down the road, or to a retinologist. That would be my answer. There's another person that made a comment that says, with COVID, now even retinal specialists wait until COVID test is negative.
Yep. But that's 20. You can, that's pretty quick though. But you're right. Every Bascom Palmer, any patient who has surgery gets a COVID test. No question about it. And if you're COVID positive and you had a retinal detachment, they're going to wait.
Right. And then there's one that says, does incoming VA help make a decision on timing of surgery? Say macula on, but 20/80.
Again, you try to determine how long they've had it. Macula on 20/80.
Yeah. I mean, that's, why is a 20/80? Is it a cataract? Then exactly. If it's a cataract doing it, then heck yeah, because that macula could be 20/20. So
yeah, exactly. Yep.
All right, we're caught up there. I'll keep an eye on that for you. And if you want to jump into lattice degeneration, thank you.
Sure. So really the fundamental question, do you worry about a patient who comes in with lattice, and maybe even lattice that's 360 degrees lattice, right? So a 45-year-old presents for an exam to update their contact lenses. You note that the presence of lattice superior, so really almost 270 degrees. What is their risk of developing a retinal tear? Is it less than 1%? Is it about 10%, about 25%? Or you think almost certainly they will go on to develop a retinal tear?
And I have that launched, Mark. It's up and running. People already rolling in with answers. It's on the Zoom side. And everyone, I don't know, a while back, I launched the handout for Dr. Dunbar's lecture. That was at 7:15. If you need it again, just message me. It will also was in the 6:45 email, and it will be in the post-event emails. All right. We'll give it another second or two here, and then we'll we're going to end it right now. I'll share the results so they can see it. I know you can't see it, Mark. So less than 1% was 37%. About 10% was 43. Oop, did we lose our speaker? I think we might have lost Mark. And then we have 25%. You guys can see it, so I don't have to read it anymore. Let's give Mark. Jay, you might have to tap dance a little bit, sing.
All right, we will do that.
Mark's calling me, so let me just.
Okay. So I'm talking about lattice degeneration. It's prevalent in about 10% of the population, somewhere between 9 and 11%. I don't usually find it commonly in older people. I usually see it in younger people, more commonly in myopes. Now, in terms of the risk of retinal detachment, whenever I see a lattice lesion, my concern is, or my thought is, there's about a 0.7% chance that they're going to get a retinal detachment from that. So if they have atrophic holes, that actually goes up to about 2%. Looks like Mark's coming back. Is that right, Greg?
Yep, he is. We chatted.
Sorry about that.
He's here.
Somehow
No
got
worries.
kicked off.
That's all right. Not the first time it's happened, and
It won't be the last.
we just tap dance and sing, and unfortunately, they had to hear us sing. But so you were at this polling.
I filled them in
Joe.
on lattice degeneration tears, and now you can come back in and correct me.
Yeah, it's about less than 1%. And this was really based, Norman Byer, who has, well, we'll get to it in a second, but it is essentially 0.7. But again, this is something I think we see in clinical practice, all the time. Represents a localized area of retinal thinning associated with a fluid pocket in the overlying cortical vitreous. We know that it puts patients at a higher risk. And so the question is, right, so somebody who maybe they do kickboxing or the MMA, martial arts, or, some activity, that could, result in trauma, do you tell them not to? And so here's an example of a patient who a lot of lattice. She wants to know if her astigmatism has changed. She ultimately wanted to have LASIK, but really she's got lattice everywhere and kind of wasn't able to capture, but a large atrophic hole, present there. And this is kind of an example, just really kind of showing it.
And I think, Mark, that the technical term for a lot of lattice is lattice.
Lattice. Thanks, Joe. And so this is Norman Byer's series. He had several hundred patients that he followed for, many, many years. And ultimately what he was able to determine that retinal detachments developed in 0.7% of eyes with lattice degeneration that were followed for almost 11 years. And what was interesting is eyes that developed tractional retinal tears, 40% of the time they occurred in areas not associated with the lattice. In other words, in areas where the retina was normal. And so that became a game changer in terms of retinal specialists no longer doing prophylactic laser. The risk of a complication from prophylactic laser was higher than the risk of having a problem from the lattice degeneration. So really, it's very unusual to find retinal specialists doing that anymore. Somebody's got retinal detachment in one eye, a lot of lattice. You still see it being done, but again, it's really rarely done anymore among retinal specialists. And so this, again, just looks at prophylactic treatment for horseshoe tears, especially symptomatic horseshoe tears, almost absolutely. But, atrophic holes, I don't know how you have a symptomatic atrophic hole, but typically those don't get treated by retinal specialists. So I typically don't even refer them. They have an operculum, maybe, especially if they're symptomatic, especially large operculated retinal hole. But yes, absolutely, horseshoe tears, I end up referring. Let me skip this one. And again, go ahead.
Sorry, Mark. Going back to the work by Norman Byer and another colleague about the same time, Matthew Davis.
Mm-hmm.
These are people who looked at a large population of retina patients with these type of lesions, including horseshoe tears, and they just watched it to see what happened. And it gave us really some very important information. But I think you and I and Greg and everybody here would realize that type of study would never happen today. I mean, they're withholding treatment from, people with symptomatic flap tears
Yeah.
to see what happens. And, it's important we got the study, the information, but it would never happen today.
Yeah. Interesting. Yeah. I never thought about that. This is a picture that tells a story. You see this inferior, this is a pigmented line, kind of atrophic retina. So this is a patient who probably had a retinal detachment at one point in time, and kind of Mother Nature, because it was inferior, retina was able to flatten itself, and patient never even knew that it occurred. And what is interesting, though, you look superior temporal, and here's a patient who, again, was asymptomatic, but superior flap tear, and you can kind of see where, I think I have a blow up of this one. They're kind of evolving into, this is all going to kind of come together if there's a little more traction. So again, that's why we look at these people. That's why you dilate. That's why you put on a 20 diopter, your indirect ophthalmoscopy, and try to carefully look. And that's obviously the case in a patient like this. So, examining the peripheral retina needs to be done through a dilated pupil. Don't substitute imaging for indirect ophthalmoscopy. There's no question that it can accent it. You'll see things on, imaging that you may not see on your exam, but at the same time, there is some limitations. You may see things on your peripheral exam that won't be picked up on imaging. So be systematic. I think you should be able to see ora serrata in all gazes, depending on, you have a good dilated pupil, you good kind of good clinical skills and techniques. If you're not comfortable with a 20 diopter lens, a 28 gives you a little lower magnification, but easier to get out to the aura. And a lot of our retinal specialists will use a 28. But again, just it really needs to be done. All right, so let's change gears. I thought we would have moved a little bit quicker, but I'm glad we had some good discussions, and I appreciate Greg and Joe being able to chime in and being able to kind of answer and talk about some of the questions that came up. So you talk about patients. Go ahead.
And the other comment I'm going to make, Mark, is I know Dr. Polito. He has a the whole thing on vitreous, and he talks about this whole lattice. And when the lattice is up against the vitreous base, I believe it's the safe zone. And when it's in that outside that vitreous base, that, he talks it about being intrabasilar versus juxta or extra. So I guess it's kind of location of it, whether it's inside or outside that vitreous base. And when it's outside, it can cause a tear. So I guess more closer to the fovea, the higher the risk. I guess I'll put it to you that way. So
more posterior.
Yeah, correct. Yep. So the more peripheral, I guess, the safer. So that's it. So
let's talk a little bit about diabetes. And again, from a clinical decision-making perspective, what are the questions that you ask yourself when examining a patient with diabetes? And there's really, this has become an interesting topic, because I think we're starting to see a paradigm shift in how retinal specialists are managing patients with diabetic retinopathy. I will tell you when I would typically refer my patients with diabetic retinopathy, but I'd be curious via a poll question, when do you refer your patients with diabetic retinopathy? Is it any time you see retinopathy? Only when there is moderate disease do you refer it? Do you wait until they have severe? Or do you refer when they reach proliferative diabetic retinopathy? So when do you refer a patient who has diabetic retinopathy? Anytime there's retinopathy, when there's moderate, when there's severe, or only when there's PDR? And traditionally, I would tell you that obviously if they have diabetic macular edema, that's an automatic referral, right? But I would wait until they develop proliferative disease, traditionally. Now, I'll tell you that's changed, and I'll tell you why in a little bit. Because traditionally, most retinal specialists would not treat. They would wait until patients develop proliferative disease. So my question always was, why would I refer it if a retinal specialist is going to really do exactly what I'm going to do? And that would be, they would follow the patient more closely if they have severe NPDR. And part of this, we'll get into this discussion, but right, one of the reasons why we categorize these patients, it's really based on what is the risk of going on to develop proliferative disease in a year. And we know that with mild and moderate disease, that risk is relatively low, 5% and 12%. But once you reach a level of severe NPDR, that risk of developing PDR in a year goes up to over 50%. And that's why, we would see those patients every 3 to 4 months. And again, that's typically what I would do. But again, as I said, that's changed for me over the last probably year or maybe 2 years.
So the results are in, and we have 10% saying anytime I see retinopathy. And we have 50% with moderate, and 38% with severe, and 2% with PDR.
Yeah.
So I guess I could have made a multiple choice, because obviously PDR you're going to refer. But I guess the question is, how back are we going? How far back before that are we going? Severe, moderate, any retinopathy? So there you go.
And so I follow I guess the rank and file, the 30+%. I mean, to me, if it's more than moderate anymore, I will refer it. And I'll tell you why as we kind of move through our talk here. So you look at the prevalence, right? I mean, 37% of adults over the age of 20 are either going to have diabetes or going to be pre-diabetic. You look this is 2012, anywhere between 1 in 10 US adults having diabetes. By 2050, it's anywhere between 1 in 5 and 1 in 3. So the numbers really are pretty significant, which is, again, you think of optometry and what we do, right? We are on the front lines of this disease. 7th cause of death. Again, 1 in 5 to 1 in 3 US adults will have diabetes. That was data from 2012. I mean, look at where we are today. And this is 2020 data from the National Diabetes Statistic Report, where you're looking at, in some regions of the country, it's really much, much higher. I'm going to try to turn my laser pointer off here. I mean, you're up to, in some regions, over 30%, which really to me seems staggering, right? So again, from an OD perspective, we are on the front lines of this disease. We see these patients every single day. The question is, do they have diabetes? Do they not? We talk about A1Cs. We talk about diet. We talk about exercise. You look at the economic impact, $327 billion a year are spent towards diabetes, which represents about $1 in $7 that are spent on diabetes. So again, these numbers really are staggering. And we know that retinopathy isn't really the only thing that's going on in a patient with diabetes. You look at their cardiovascular mortality rate, 1.7 times greater than the non-patient with diabetes. Strokes and hospitalizations about 1.5 times greater. And so it becomes, pretty significant. But the bullet up top to me is really kind of that patients with diabetes go on approximately 24 doctor visits a year. That's to me really pretty significant, right? And you think about, yes, we want patients to come in every year for their annual eye exam, but remember, that's not the only thing that's going on in the life of a patient with diabetes. They're seeing their endocrinologist, their nephrologist, they're seeing their dentist, their diabetic foot doctor. I mean, the list goes on. And yeah, it's great if you get paid time off, or paid sick time, but that doesn't represent everybody, right? And some people, if they're seeing, a doctor, they don't get paid for their sick time. And you think about cost of copays and really a number of factors that can influence why patients aren't coming in to see their eye care provider. And I think we have to be a little bit sensitive to that. So I said, this was kind of the traditional management, right? You'd kind of mild, moderate, you'd see them almost 9 months to a year. If it was severe NPDR, you'd see them every 3 to 4 months. PDR, referral, any CSME, we would refer these patients. But again, the trend is really towards referring these patients earlier. And there's good data to perhaps support maybe treating these patients before they develop proliferative disease. This is the diabetic retinopathy severity scale that I think most of us are familiar with, right? Mild, moderate, severe. We know that the risk of vision loss becomes greater as the disease progresses, which again, you look at our stop sign, red, yellow, green, yellow, red, kind of obviously makes sense. The worse the disease, the greater the risk of vision loss. And again, it's all predicated on what is a risk of going on to develop PDR. And again, we know that once they develop PDR, the risk of vision loss becomes greater. And so many of us use this 4-2-1 rule: significant hemorrhages and microaneurysms in 4 quadrants, significant venous beating in at least 2 quadrants, IRMA in at least 1 quadrant. Any of those categorizes a patient as having really severe NPDR. And this is from the IRIS registry. So the Academy of Ophthalmology has a registry for really AMD, diabetes, tumors. I mean, there's a number of things that they want to kind of look at as the population at large. What is the incidence? And so from their IRIS registry data on patients with diabetic retinopathy and their 2-year risk of sustained blindness without treatment based on 53,000 eyes, patients with PDR, of course, we know have a 4 times greater risk of having sustained blindness compared to a group of patients who have mild NPDR. But again, you look at even severe NPDR, their risk of really having sustained blindness, I think, which was by definition 2100 to 2200. So it's not blindness, but again, significant vision loss by any means. But their risk is almost as high as the PDR group, which again, when you look at risk of vision loss, I think it's a sobering statistic. So we looked at a version of this a few minutes ago. And so what you'll see sandwiched here really is another categorization. We go from moderate, and between moderate and severe, we have moderately severe NPDR. And as it turns out, this moderately severe to severe becomes kind of a critical window. And again, not that any of us, even among retinal specialists, are clinically skilled enough that we can distinguish moderately severe from severe, right? So we talked about what is that 4-2-1 rule, hemorrhages and microaneurysms, 4 quadrants, et cetera. Well, that moderately severe, if you have it in 2 to 3 quadrants, or venous beading, not in 2 quadrants, but 1 quadrant, that puts a patient in this moderately severe NPDR category. And so again, big picture, there's really a couple other grading systems that have been developed. When the early treatment of diabetic retinopathy study was going on, this was this middle one, this ETDRS grading. That was a scale that starts at 10 and goes up to 85. They kind of developed this modified version, which was a 1 through 9. And the point of this is these are really done for the sake of clinical trials. So again, you think about clinical trials, the doctor sees the patient, they grade the patient on the level of retinopathy, patient gets, fundus photos taken, and then those photos get sent to a reading center. Then the reading center is the one that really kind of looks at really more carefully, and they're the ones that will kind of categorize maybe a level 35 or a level 43, or, on the modified scale, they'll kind of put them into here. And so, as I said, as it turns out, this level of 47 to 53 really becomes kind of the sweet spot in diabetes, where perhaps retinal specialists are talking about maybe intervening. So instead of waiting till they develop PDR, maybe this level of 47 to 53 really becomes kind of the entry point of anti-VEGF therapy, if you will. And I'll talk about that in a second. We know that most patients, with macular edema, 90% of vision loss, that's from diabetic macular edema. So again, from a clinical decision perspective, question I would always ask, do I see any retinal thickening? Is it clinically significant? Is it within 500 microns? And again, I think this is a nice schematic that kind of talks about really what retinal thickening looks like. Of course, in the era of OCT, no longer do you really have to guess, right? I remember, and I'm sure Joe remembers, when we put contact lenses on these eyes and try to determine is there retinal thickening, and we got to be pretty good at it, but gosh, you look at where we are with OCT and it really does take the guesswork out of it. You can see really architecturally what's happening. You see the retinal thickening, you see the cystic spaces, you can kind of correlate these higher reflective areas where the exudate is. And again, I think our sensitivity of being able to diagnose it becomes much greater. Most of us learn this definition of clinically significant macular edema, and probably all of us can recite it like you would recite a Bible verse, right? You kind of look at the patient with retinal thickening with 500 microns, et cetera. And, here's some examples of patients who had clinically significant macular edema. But, the fact is, in the era of anti-VEGF therapy and in the era of OCT, that definition is really fallen by the wayside. It's really nothing more than almost a footnote in history, because now among retinal specialists, the question is it center involved or not center involved? And that's really what they base a decision on, whether they're going to put an anti-VEGF drug in. Maybe, yes, it's clinically significant, but if it's, not center involved, many retinal specialists will just choose to follow the patient. So center involved versus non-center involved really becomes kind of the buzzword that you want to use when you're making a decision to send a patient to a retinal specialist. Is it center involved? And that's within that central subfield on the OCT. And again, I will look at the thickness map, and that's really kind of the best tool to kind of look at, is it center involved or non-center involved? And again, here's a patient that, if you looked at the B scan, it looked pretty well, but this is a horizontal and a vertical, but you look at the thickness map, and this is a patient who's got non-center involved diabetic macular edema. And so, I may still send it because we know that, again, there's a threat to visual function, but I think you could even choose to watch it if you wanted to, if it's not center involved. Maybe the patient gets her blood sugar under better control, changes diet, etc. The diabetic macular edema goes away. But again, thinking, is it center involved versus non-center involved? And again, I don't want to get into the minutia here. This is just what I call the ABCs of DME. And this was really the drug companies and the diabetic retinopathy clinical research. Now we're going through clinical trials, essentially establishing the effectiveness of the anti-VEGF drugs, being better than traditional laser for patients who had diabetic macular edema. An example, here's a patient who was randomized to one of the clinical trials. You see they've got quite extensive diabetic macular edema. They have multiple anti-VEGF treatments for their diabetic macular edema. And of course, I think this is probably 24 months or a year out. You see the diabetic macular edema goes away. But the other thing you really want to look at, and this is really what kind of captured the attention of the people doing the clinical trials, is look at the extent of the retinopathy. Not only are we, getting rid of the diabetic macular edema, but you can see the level of retinopathy is much better. And so in a sense, we were able to kind of turn the clock back. Here's another example. This is a patient who kind of slipped into one of the RIDE or RISE clinical trials. They had actually high risk PDR. They get multiple injections for diabetic macular edema. And again, I don't have the OCTs, but the point is, look at the level of retinopathy, the extent of the retinopathy, at 24 months after treatment. And yes, the diabetic macular edema goes away, but you also see that the level of retinopathy really gets better. Here's another example, almost the same thing, right? Before treatment, after treatment, we were in a sense able to turn the clock back. And so this kind of brings up this Theta 47, which was really one of the clinical trials that Regeneron really launched. Really, the question is it better, instead of waiting till they develop proliferative disease, is it maybe better to treat early? Would earlier treatment result in better visual outcomes? And maybe would it result in a less number of injections than if we wait till they develop PDR? And, they didn't really look at or talk about the cost or burden of treatment, but it's one of the questions that, you can't help but wonder, right? If we're treating these patients earlier, what is the economic impact? Or, the idea that our retinal specialists are already pretty busy, not only with AMD, but diabetic retinopathy. If we're going to intervene earlier, really, what does that do in terms of the burden of treatment? Try to get my slide to go forward. There we go. And so this is a study that was launched by Regeneron. This was a prospective phase 3 double mask randomized clinical trial, really looking at this level of 47 to 53. They followed them initially to week 24 and then really up to over 100 weeks. And now we've got, I guess, 2-year data. So one group gets followed, one group gets treated with aflibercept or Eylea. You'll notice Charlie Wyckoff is the lead author. Charlie is the lead author in another study that I'll show you as well. And they had, different treatment algorithms. One group had treatment every 8 weeks. The other group was treated every 16 weeks. And essentially, they were, again, looking at this 2-step improvement from baseline. And so, again, you can really see a big difference, right? You're looking at 60% of patients having a 2-step improvement compared to really hardly any of the patient that were in the sham group. That was 26-week data. Here it is at 52 weeks or a year, and almost the same thing. You're looking at really a pretty significant impact in terms of patients having a significant improvement in their level of retinopathy compared to the groups that had kind of the sham injection, if you will. And this is, again, percentage of people looking at 24, week 52, and then week 100, again, having that 2-step improvement. Well, the other thing that they did is they looked at the percentage of people in the sham group who went on to develop either PDR or anterior segment neovascularization or both. And so this is really risk reduction. So you're looking at really almost an over 80% risk reduction in the treatment group compared to the eyes that weren't treated in terms of going on to develop either proliferative diabetic retinopathy or center-involved diabetic macular edema. So again, we're preventing all these visual threatening complications. Not only are we turning the clock back, but we're really preventing the development of diabetic macular edema and proliferative diabetic retinopathy. So again, they really pretty powerful numbers in terms of really an argument for maybe why these patients should be treated earlier. And so this is a study that was a Regeneron study. This is the Genentech study, and theirs wasn't a prospective study. This was a retrospective study. And again, we're looking at Charlie Wyckoff. So again, working really both sides here, if you will, but they looked at their pivotal data from the RIDE and RISE. Those were the clinical trials that led to the FDA approval of Lucentis for diabetic macular edema. So again, 750 patients, if you will, again, that were randomized in this study. And again, almost really the exact same outcome that we saw with the Regeneron study, that moderately severe to severe NPDR patients having really a significant regression in the level of retinopathy. And again, the idea, well, do we treat even earlier? And again, not quite the same numbers, but not like what we saw with mild moderate. Again, much less threatening retinopathy doesn't seem to be a benefit. Again, you look at these mild to moderate, PDR patients, again, a benefit, but not like what we saw with that moderately severe or severe NPDR patient, really being able to really make a significant difference in the level of their retinopathy. Now, the only thing I'm going to draw your attention, we've talked really only about this two-step regression, and that was really the purpose of the study. The one thing they didn't look at was vision, right? So theoretically, all these patients, well, I shouldn't say that, but so the question is going to be, so do we have any effect on vision if we treat earlier? So you have a group that we wait till PDR, and then we have a group that we're treating before they develop PDR, but what is the ultimate visual outcome in these patients? Do we lose anything? Yes, we're maybe able to turn the clock back, but do the eyes that aren't treated go on to develop PDR? Is their visual outcome worse than the eyes that were treated? And that's really kind of the $1 million question. By the way, this is kind of what a two-step improvement looks like, right? That level of 40, I guess it was 53 doing to level of 43. And so this is data that was actually just published a month or two ago. This is really from the Diabetic Retinopathy Clinical Research Network, the DRCR net. So we're looking at studies that were done by the drug companies, right? Well, this is a study that was done really funded by the National Eye Institute that essentially did the same thing that the other two companies did, right? They wanted to know, is there a benefit of treating these patients earlier before they develop PDR? And then the proportion of eyes that develop PDR, vision threatening, center involved diabetic macular edema. So they ended up really almost getting the exact same outcome, right, as the clinical trial. So it supported the fact that you're able to get a two-step improvement. However, through 2 years, preventive treatment did not confer a visual acuity benefit compared with the observation plus treatment with the aflibercept group. So in other words, they were able to essentially show the same thing, right? And here's their study, a sham group versus a treatment algorithm every 16 weeks. And essentially you're looking at the time to develop of either diabetic macular edema or PDR. So there's no question you were able to slow that development in the eyes that were treated compared to the eyes that were observed. However, so what happened was when the eyes that develop PDR, right, then they're getting anti-VEGF therapy. At 2 years, there's really no difference in visual outcomes. So the point being that, yes, we're able to turn the clock back by treating them early, but it doesn't, in a sense, result in a better visual outcome than if we just wait and let the patients develop PDR. Now, the authors concluded, well, 2 years maybe isn't enough time to be able to know what that benefit is. And ultimately, they're going to try to determine, is there a benefit out to 4 years? But I thought that was interesting, right? So what if the benefit of early treatment, if it doesn't result in any visual acuity benefit? And so does it matter that there is regression in the level of diabetic retinopathy? When all is said and done, the patient ends up with the same visual outcome. And so I think it's interesting because there is this momentum shift among retinal specialists to treat early. And so by the same token, there's really, I think, a responsibility from the OD if you're seeing these patients, with any level of diabetic retinopathy, not any level, but more than moderate, to make sure these patients get sent to a retinal specialist, even though, they may or may not be treating these eyes. But again, there's a growing momentum. So I think it's an interesting kind of discussion on where things are headed and if this is really going to be kind of the outcome. This is kind of my algorithm on how I see vision loss in patients with diabetic retinopathy, right? So you look at the mild to moderate eyes, they do very well for a long period of time, for really many years. It isn't until you kind of hit that severe mark that boom, you've got that narrow window, right? So things speed up very quickly. And obviously by the time you get PDR, the risk becomes much higher. So again, the idea that if we can intervene earlier and turn the clock back, perhaps really that may be, in the long run better. But again, as I said, we're really not seeing many retinal specialists embrace this yet. I think, recognizing that, well, if they have diabetic macular edema, yes, those eyes are going to be treated anyway. And if you kind of watch them very quickly, right, or very over short intervals, a lot of them will go on to develop PDR. And again, that being kind of the barometer anymore. So it's interesting to see if these retinal specialists are going to really kind of embrace this, intervene earlier, with the idea that it may not result in a better visual outcome. Any thoughts or comments?
The chat box is quiet, and no, I mean, there's definitely that changing paradigm, and we're having it out here. I'll send patients over with that kind of moderate to severe, and they're injecting them at times without the macular edema. So
yeah, it's interesting. So let's kind of shift gears, and again, we'll talk a little bit about kind of macular degeneration now, right? So this becomes the clinical decision. You see a patient who's got drusen, maybe extensive drusen. Is there fluid, right? And then kind of what level of macular degeneration is it? That becomes important from a clinical decision perspective. And then maybe thirdly, at what point do you start nutritional supplements on a patient with macular degeneration and drusen? And, we're not going to get into the discussion of low versus high zinc versus no zinc. That could be a discussion for another time, but I think the other two and three kind of points I think are pretty significant. So this is, I think, that the typical macular degeneration case that for me and probably all of you, when you see this patient in your practice, in the absence of having an OCT, this becomes, I think, a very difficult patient to be able to maybe not manage, but right, being able to answer the question, is there fluid? Is there choroidal neovascularization present? Because, you look in these coalesced drusen, sometimes, is this a little shallow PED? And again, you look at the modeling here and again, that combination, sometimes it looks like there's some thickening or elevation. And so again, before OCT, these are the ones that, I'd kind of sweat a little bit. I'd put a contact lens on and do I see any thickening? And, of course you look for subretinal hemorrhage and you look for exudates, but these were the ones that I think were really challenging. And again, if you have an OCT, it really becomes, I think, a very, not a simple question, but really kind of helps you in terms of being able to answer that question. Because again, we know the more the extensive disease, the more advanced the dry macular degeneration, the greater the risk that the patient can go on to develop choroidal neovascularization. And this was actually over a 3-month window, right? We see the patient, there's this little suspicious area here, and this is before we had OCT, did a fluorescein, it really wasn't conclusive, and patient comes back 3 months later, big subretinal hemorrhage, and of course, an occult membrane, and that was the time when we were doing traditional laser, and so they don't really have a very good outcome. Here's another kind of example of that, right? Where you look, you try to answer the question, is there any fluid? Is there any hemorrhage? Is there exudate? And again, you think about a patient, they've got a little bit of a cataract, they may be a little photophobic, they're not giving you the best view into the retina. And so again, in the absence of having an OCT, that becomes, I think, a very difficult question to be able to answer. And so here's an example, and you look, this patient had a little bit of subretinal fluid. Nice PVD here, but this is a patient who's probably got early choroidal neovascularization that, again, only able to pick it up because, we've got really sensitive imaging to be able to capture that image. And so, yeah, without an OCT, I think it can become a difficult question to be able to answer. Here's another example, Olga, and she had cataract surgery and we get a great view, but gosh, you just see extensive drusen. And again, the idea that some of these drusen, they coalesce and becomes hard to differentiate whether there's an early choroidal neovascular membrane present or not. And so, yeah, you kind of look, you see these drusenoid changes, but there's no intraretinal fluid. There's no subretinal fluid. And this kind of higher reflective area probably represents that little bit of pigment change. So again, this is an intermediate level, even though they don't have choroidal neovascularization today. I can tell you their risk over the next 5 years is probably over 50%. So this is a patient that I would tell you should probably follow this patient at least twice a year, if not more than that.
And Mark, if I can throw in a clinical pearl, which
I'd love to.
many people do know, but sometimes you don't think about it, is don't just look at that one cut that ends up from your technician in the medical record. If you have to, go to the device itself and scroll through every cut, because you may have something a little ways from the fovea.
Exactly right. It's a good call, Joe. Good call. And in the beginning, when we first started, we weren't doing that as much, right? Now we look at every single cut because, to Joe's point, and is including the thickness map, because there is a lot of information, and you can have an eccentric choroidal neovascular map. For example, this, right? You look inferior and you see these coalesced drusenoid PEDs that really look pretty suspicious. But yeah, to your point, Joe, you look at this cut right through the macula, and it's not down here, so you could easily miss it. But this patient, of course, didn't have it, and they're 20/20 visual acuity, but again, having the ability to have imaging really does help you, I think, make these clinical decisions on patients. And so, the kind of the question again from a clinical decision perspective, what level of macular degeneration is it? And if you do ICD-10s, right, they will ask you, is it early, intermediate, is it advanced? And it becomes important, particularly with intermediate, because so much happens at that stage. That's really the stage, I think, where you should begin thinking about nutritional supplementation. That's the stage where, again, we know the risk over a 5 or 10 year period of going on to develop choroidal neovascular membrane becomes, I think, significant. And then you kind of look at, this patient can go in one of two directions. Well, maybe three. They can be very stable, right? There's about a 10-year risk being almost 50%. They also say the 10-year risk of central geographic atrophy being over 50%. I'm not sure I believe that, but this is data that was generated from, I think, the age-related eye disease study, and as well as Brad Ferris's group out of Hopkins. So, but again, the idea that I think you need to start thinking categorically. This is geographic atrophy, and I think part of there's a little bit of hype and attention because we're going to probably in the next couple of years we're going to have an FDA-approved treatment for geographic atrophy, and the companies that really know this are having treatments recognize optometry is on the front line, so they want us to really be on the lookout and recognize that geographic atrophy is more common than what we maybe traditionally have thought it is. This is the Beckman Committee classification of macular degeneration. And again, you look at the difference between either early macular degeneration or intermediate macular degeneration. Again, medium drusen between 63 and 125 microns. And so let me just skip to this slide, right? So you think, well, what is 125 microns? How can I put that into any kind of clinical perspective? And so I think of 125 microns being about the size of one of the branches of the central retinal veins. If you've got drusen that are at least that size, and you got at least one of those drusen, categorically, that puts that patient at an intermediate level macular degeneration or any pigmentary abnormalities. Now, this patient has a little bit of everything. This one, you look at some of these larger drusen, and again, categorically, that puts it at an intermediate. I'm not sure about this one, right? And so that's the question, that when you're looking at these little small drupelets, and I'll back up. So, between 63 to 125, right? I would probably put that more at an early, but again, that becomes ICD-10 classification. And it also really becomes the breaking point of when you would either recommend home monitoring and or when you would recommend putting a patient on a nutritional supplement.
Hey, Mark, can you go back one slide? Because I do a macular degeneration talk, and I just want to remind everyone the size of the macula. And the macula is 5.5 millimeters in size. I think a lot of us think the macula is the fovea, right? So remember, you have the foveola, you have the fovea, you have the peripheral, you have the peripheral. And if you just think about the disc, the optic nerve head, it's 1.5 millimeters or 1.8. It's basically the macula is just inside the arcades, 5.5 millimeters is like 4 disc diameters, maybe 2 from the fovea, two up. So the macula is pretty good, pretty nice size. So it doesn't just have to, all these
Yeah.
ones that in that
They're
middle
out
picture
here.
are kind of like, yeah, there you go. They're like foveal drusen that you have there. And you have one that's still out there at that top one marked. If you point that one out,
Yeah.
that is still in the macula, people. That's the macula way out there. So if you had no other drusen in that foveal region, and you had that one intermediate right there, that would still be intermediate macular degeneration. That's it. That's what I want to say.
Yep. So again, I'm not on an advisory board for 4C home, but I do recommend it. I've got several patients, probably a half a dozen, maybe more, that I recommend it. So if they reach this intermediate level, I will just talk to them about, there's a device that we can put in your home. I write a prescription that's hooked to our electronic health record. And basically it gets sent to the folks at 4C. They do all the heavy lifting in terms of calling the patient, installing it, teach them how to use. So it's really a very simple discussion to have. But for somebody who you think has this intermediate level and or a high risk, I think, the idea of having a home monitoring for macular degeneration makes a lot of sense. And this is, again, when you look at both, the age-related eye disease study in one of their arms, they looked at, the ability to diagnose these choroidal neovascular membranes earlier. So this is the AREDS study. And then I talked about the IRIS registry data, right? So this is their macular degeneration. So the idea, the percentage of patients maintaining functional vision by using the 4C home device at the time of diagnosis. And again, the traditional care being about a third of the patients. If you use a 4C home, it was 83%. And this was kind of IRIS real registry, real world data. In the age-related eye disease study, it was over 90%. So again, from a clinical data scientific perspective, I think there's good rationale for recommending it, and I do it, and it's not a heavy lift discussion. It's very simple and easy, and again, it's linked to our electronic health record.
Yeah, my end, Mark, I just started doing it this year, probably around March or
Yeah.
June, and I have an N of 4 people, and I haven't had anyone that created an alert yet. But yeah, I do agree that this is a great tool that's out there for our analysis. And a little reminder to everyone is, the idea is when someone comes in and they bleed, if they're 20/80, if they're 2100, and when you see them, if you inject them, they will maybe get a little bit better in their vision. But the statistics are now showing that they'll just drift back to about where they were at the time of diagnosis. So if they come in and their count fingers, they might improve. They'll probably be count fingers. If they're 2200 and they improve, they'll probably drift back to 2200. So the key is with this device is that if you catch them and then it's alert and you catch them early and they're 20/40, that's a heck of a lot better than 20/80. So
Like
that's
any
really the
disease,
beauty
if you
of
catch
this.
it early, especially when vision's good, there's a better chance that they will maintain, functional vision being 20/40. So that's exactly right, Greg. I've had 2 alerts and they've all been false positives. So, but again, they get alerted, I get alerted, we bring the patient in, and some of the retinal specialists will complain that there's too many alerts or too many false positives. But again, I think I'd rather have false positive, bring them in. All right, you're doing it. We're looking again. They feel better. You feel better. And right, we're going to go back and we'll continue to watch it. But I think it's really, I think it's worthwhile.
Let me just point out, Mark, because I think it gets confusing. This is not another piece of equipment that you as an optometrist needs to buy. As Mark mentioned, you prescribe it and then the company sends it to their house. You make no money off of it. And I'm going to say that with a little wink, you can make money off of it because this is data to review when the patient comes in. So with the new ICD, not the ICD-10, but the new E&M coding that's out there, you're able to review data now, and then you can charge for that when the patient comes in. So it's not like, oh, geez, I have to buy another piece of equipment. Nope, you're just prescribing it, and this gets sent to the patient's house, and then they train the patient.
If patient has, and it's covered by, again, intermediate AMD, it's covered by Medicare. And if they have a supplemental insurance, it's really, they don't pay anything. They may pay, if it's just strictly Medicare, I think there's I don't know, like an $8 or a $20 fee. It's per month. It's nothing, but a lot of patients have supplemental. So, but it's not, economically, it's not, then it's not expensive for a patient per se.
I'm not sure if you have how this works coming up here, Mark, but I did get a private message. It says briefly describe the 4C method of detection and what causes the alert. And if you want to go over it, or I can go over whichever.
I'll go over it. I mean, we didn't, because this wasn't a talk on the 4C home. I just wanted to tell you from a clinical decision perspective. I use it. I recommend it. So it's based on the idea of preferential acuity. So when the patient looks in, there's a distortion, an artificial distortion that's created in each eye. And the patient, with a button is able to kind of look or notice where that distortion is, right? And so they do this, every day or every couple of days. And they're used to seeing this distortion. And so what happens with macular degeneration, if there's any exudate or retinal thickening, that distortion becomes greater than what the normal distortion is from their preferential acuity, and it sends an alert. Essentially, that's it. Can you say it better than I do, Greg? You might be able to.
No, I think, I'll say the same thing, maybe a different way, is that, the machine is creating a bump somewhere.
Yep.
And the patient's supposed to click on it. And if the patient is developing a choroidal neovascular membrane, they're going to keep clicking where the membrane is, because that's where they're seeing the line being distorted. So they're just clicking on the wrong area, and then the patient gets then you get an alert. So
perfect.
That's it.
We're almost out of time. The only thing I wanted to kind of talk about again was again from a clinical decision perspective is and let's not go to the question. Let's kind of skip through the question for the sake of time. When do you recommend nutritional supplements, and do you, on any patient with AMD, on a certain level of AMD? And I would tell you, we're familiar with the age-related eye disease study data that a nutritional supplement for patients who had intermediate level AMD, you're able to reduce that risk of progression by 25%. Interestingly, even the zinc group were able to reduce the risk of progression by 21%. But here's, I think, the crutch of it, right? So they were unable to determine a potential benefit in patients who either had no AMD or early macular degeneration. In fact, when they developed the study, remember in the early group, there was over 1,000 patients. They had kind of projected it over that 5-year window. There was going to be about 50 people that they thought would go on to develop choroidal neovascularization. As it turns out, over that kind of 5-year period, only 15 patients progressed. So again, you look at a probability perspective, only about 1.3. And so that's why they didn't recommend a nutritional supplement for people who either didn't have any macular degeneration or only early macular degeneration, because again, you look at that probability is about 1%. And so you think, is that the economic toll, taking a pill, these aren't easy to take, they can be pretty big. And so would you really recommend it to a patient? And I tell patients that. No, it won't harm them, generally speaking, but if you're prescribing it because you're worried about the risk of developing choroidal neovascularization, that risk is really only about 1%. And so for me, again, from a probability scientific perspective, that's, I typically won't recommend it in somebody who has either no AMD or very early macular degeneration. So with that, I think,
hey Mark, I'm going to make a comment on that. And because I started about 3 years ago trying to unearth this monster. And I agree. I probably would not recommend the AREDS formula, because you're really just giving lutein and zeaxanthin, maybe some zinc and some copper, which is because of the zinc depletes it, and so on and so forth. But maybe there'll be another lecture at some point that I'm in the process of building. Is we don't really treat the problem with just lutein and zeaxanthin. That's kind of the stuff that's in the inner retina, and we keep showing all these diseases and these pictures, and it's out of Brooks membrane in the outer retina. And, I'll kind of end it with kind of the curiosity of, we need things like polyphenols and flavonoids, which are, quercetin, which are resveratrol, catechins, and green tea. And I actually are starting to get, by using some formulations of drusen disappearing. So stay tuned that are out there with that. So, because, we always say the crime must fit the punishment. Well, I agree. I don't think the crime's fitting the punishment here, because we're just using 2 carotenoids, which are extremely important in that inner retina, making that second lens and doing the free radical and the blue light absorption. But we're not really treating the outer retina with where the disease process and all the inflammation and oxidative stress is. So kind of stay tuned, and we'll see what we can dig up a little bit later on that. So.
All right. Well, with that, We didn't get through near the stuff I was thinking we were going to get to, but I really enjoyed kind of the discussion and the people interacting and asking the questions. So I think that's a lot of fun, and I appreciate having Joe and Greg to offer their perspectives and insights. It makes it really, I think, a lot of fun and hopefully interesting. So thank you guys, and thanks for everybody for taking time out of their Sunday night.
Well, Mark, it was interesting. It was well developed. You really had a good concept of clinical decisions, and I think you really delivered on
Thank
that material. I think that the engagement by the audience, the questions by the audience, really indicates, probably even better than polling questions, the true engagement that they all had. So this was a tremendous discussion in Retina, and I really enjoyed hearing it, and I think everybody really appreciated it. We certainly hope to have you back for our webinar series before the COPE allowance expires in 2022.
Great.
And I'll echo the same thing, Mark. I'll just kind of wrap up here with thank you and thanks for taking clinical decisions in Retina. Mark, you did a great job presenting. Joe and I
Thank
were
you,
here
guys.
as moderators, and we had Vanessa here as our COPE administrator.